Five, four, three, two, and one. I think we're live right now. Great. So we're live.
Okay, excellent. Well, thanks. Thanks very much. And hi, everybody. My name's Brian Scarpelli. I'm your moderator for the next panel here on here for the Big Unlock virtual forum. Our panel focusing on health and science. Thanks so much for joining us today. I can give you just a brief idea of this panel really quickly. I'll tell you who I am just for background, but this is not about me. This is definitely about the experts that we have here on the panel. Really quickly, I'm a lawyer for a not-for-profit trade association, an effort called the Connected Health Initiative, which is a policy and legal advocate on digital healthcare issues. And you can imagine as you probably imagine, we've had a great amount of focus on the policy issues related to the COVID-19 public health emergency and global pandemic, and so that you can probably also imagine why I'm quite excited to be a part of this session. We have lots to talk about. I probably should not read off lengthy bios for all of our panelists, and they're going to, in a moment, give some introductory remarks and introduce themselves to you. But our idea here today is to talk about generally how connected health technology is making an impact now in the context of these unique times, this COVID-19 pandemic, and what that really means for the future of healthcare. Looking to touch on federal and federal statutory and regulatory issues and how they impact us, how the tech is being used on the front lines today, which is very important for us to understand, I think, across the spectrum. And not only how new technology capabilities are addressing the coronavirus itself, which is very important, but also other conditions around that and generally in healthcare due to social distancing. Also insights, I think, very interesting from the venture capital industry, et cetera. So very briefly, we are joined by Dr. Wilson Wang. He's founder and CEO with Walking Doctors and a pediatrician at NYU Langone Health. Dr. Joseph McMenamin, who is the principal at McMenamin Law Offices. Dr. Nanda, founder and CEO of Align Telehealth and Asana Medical Group. And Michael Thomas, CEO of Appian Partners. So I believe we were going to just, again, give some brief remarks, have each panelist give some brief remarks, tell you who they are, and share some initial insights, and then we can get into Q&A and discussion. And I will be keeping an eye on questions that you all out there in TV land would like to submit. So please do engage with us as we move forward here. And that is more than enough blathering for me. I think first up, we were going to go with you, Wilson. Go ahead.
Okay, it looks like the screen sharing has been disabled. Brian, is that possible? Because mine's not. Oh, no, I think I just got it now. Thank you so much. I just got it. So it's such a pleasure to be able to speak to this virtual audience, who I can't see, but I know from the list that they're coming from very interesting backgrounds. It's such an interesting time. I'm Taiwanese American, and I have to say during this pandemic, I've been called a lot of interesting things, including Chinese, I think pangolin. But on the bike ride over here, I swear someone called me a mango. And I was just thinking to myself, how did they know that I love mangoes so much? In the 4 minutes I have with you all, I just really wanted to talk about the importance of using health technology to structure the patient-provider encounter to prevent mistakes, and so that we have real good quality data for the public good. I've been working as a physician in the emergency room in the hospital ward since the beginning of the pandemic. And I have to say that it's been sort of just a continuously scary experience. It's not because of bad intentions, but by definition, doctors don't train on novel pathogens. There's a lot of confusion during and even now about what were the recommendations. We were told at the beginning of the pandemic, for example, that there were 1 million swabs out there, but I swear there weren't any swabs for at least a week to test patients about COVID-19. And so we did our best, but most people would agree that we could have done a lot better, including the patients. You know, in the ED, we often discharge people on Tylenol and cough medicines and just told them to go back and quarantine, knowing that the details and the support for quarantine wasn't really going to happen. If patients were admitted, they were put on chloroquine and azithromycin. The studies had shown in many other countries that this was not an effective therapy. Later, we learned a lot, including that chloroquine kills people, and we still could not disseminate that information beyond our individual facilities. And meanwhile, public health departments essentially pleaded with us to call them when we had deaths, if we had certain types of cases. And because we were busy, I would say more often than not, we did not answer the call. So, you know, sharing matters, and I think especially in the current social upheaval that we see outside in our streets, that we can draw an analogy that the healthcare system needs a type of virtual body cam. The idea of this is that this is an important enough endeavor that multiple eyes increase the performance on the prize, and that we should be happy to add transparency to things of importance. And this doesn't have to be a scary thing. You can imagine that the body cam of the 21st century is not just a recording instrument. It can actually help the wearer, let's say, decide if a situation is dangerous or not, or if a treatment is appropriate or not, or if a pre-treatment just is plain dangerous. Doctors, you know, so here's the current body cam that we have in the system. But I have a company that produces a different type of body cam. So in this system, what happens is that the provider, when they, after seeing and examining the patient, they decide on what is the diagnosis. And in this case, I'll just pick Kawasaki's disease because a lot of people have been worried about that in the pediatric environment. And they select what they think that diagnostic, and then they provide care with support. So in this example, that the provider is told explicitly that the diagnosis of Kawasaki's depends on fever and 4 exam criteria. Now, some providers might not know all those criteria, so they can actually look in line with their care and say, okay, that is what the oral mucosa changes looks like in Kawasaki's disease. Or, did I see the right thing with regards to the hands and feet? Oh, no, that was not what I saw, et cetera, et cetera. And as they complete all the lists, the diagnostic criteria, then the system actually gives them the grade. And in our system, you can actually see what constitutes a grade of a quality diagnosis by looking at a rubric about documented actions in care. Just really another quick example of treatment. Doctors are actually okay with getting support as long as they know that there's science behind it. So in this example, we could see that in our charting, that the provider can click on a reference to say, okay, what constitutes the background, and then click the article itself to see that, okay, yeah, this thing is something that I can agree with. And having that, they have no problem adhering to protocol, including not giving chloroquine or antibiotics for treatment of Kawasaki's, because that's dangerous. And they verify this in our system. But things like immunoglobulin therapy, aspirin therapy, no problems with the recommendation. You don't even have to do it if you don't want, but it does give you a grade. It does do automatic dose calculation. And again, for such an important outcome situation. People deserve, the public deserves, the provider deserves, public health bodies deserve to know what constitutes complete care. So indicators matter, and you can imagine that by structuring care in a way that we can then not only look at Kawasaki's disease, but look at all other diseases. And we have about 275 diseases and conditions that we look at. And then what we do is that we de-identify, aggregate, and then we publish this for public health bodies so that they can see what is the health status of the community, where are the hotspots, where are the success stories, and share that information to the public and devote essential resources to important things. So in this graphic, which our providers can always see and our public health bodies can see, it's not only Kawasaki's and coronavirus that are important, it's all the diseases. And then you can see the performance on the diseases based on those rubrics that you saw further. And God forbid there's things like deaths, but sometimes it is important to realize so that no life goes wasted. What are the details with regards to that case? And in real time, certain people in our system can open up the chart and see that how individual provider patient quality data is directly impactful to the public's health. So I'll stop right there because I know that was just really introduction to our system and my sort of line of thinking. Thank you so much.
Excellent. Thank you so much. Joe.
Okay. Thank you. I appreciate it. Thank you, Wilson. If I can figure out how to do this, I will happily share my screen. I'll see here. If it's all right with you, maybe I'll just dispense with that and just offer some remarks. I had only a couple of slides anyway, so let me just offer some thoughts from a legal perspective. What has been impressive to me, among many other things, during the course of this PHE, public health emergency, has been the extraordinary growth of virtual care services. There's been something like a 4,300% increase year over year between March 19 and March of 20 in telehealth insurance claims. In March of 19, only 0.17%. So that's what, 1/500th of medical claim lines were related to telehealth. Now it's 7.5%, which is orders of magnitude greater than we saw just a year ago. The increase has been particularly pronounced in the northeastern states, which have been so hard hit. New York, New Jersey, by the COVID-19 problem. The increase there has been an astonishing 15,500% just over a year ago. There's also been a dramatic increase in popular support for this kind of healthcare. Something like 76% of consumers now favor the use of distance care, and 74% who have used it have expressed high satisfaction with it. What accounts for all of this? Well, I think to borrow from medicine, it would be a multifactorial etiology, so to speak. There are many reasons for it. But what I want to focus on, and what's of greatest interest to me professionally, is legal issues. This kind of care at a distance, care where the provider is in one location, the patient is in another, has been around for decades, but its growth has been slow and halting, and it has never come anywhere near reaching its potential. A big reason for that, or so I think, is legal impediments to its growth, particularly reimbursement. And one of the contributing factors to the growth that we've seen in just this last year in this form of care has been significant change in the extent to which we are enforcing laws that still exist and are still valid, but in an effort to expand access to care and to diminish the risk of both the providers and the patients engaged in that care, governments, federal and state, have changed laws, or more accurately, have decided not to enforce laws in ways that have greatly expanded access to care. The biggest such change, by my lights at least, is that in a great many states now, the requirement for licensure to practice in that state, to provide services at a distance to patients in that state has been waived. So states are not enforcing the law that would otherwise require doctors from outside the state to be licensed there. This greatly expands access to care. Reimbursement, payment has also been changed in material ways. For one thing, there's just substantially more money. The federal government is spending money as I have not previously seen it for healthcare, including distance care, telemedicine, telehealth. There are also a great many fewer restrictions than we have previously experienced. For example, it is no longer necessary for Medicare and other federal healthcare programs, that the patient be in a rural area. He could be in the heart of Manhattan. The patient need not be in a healthcare setting, such as a doctor's office or a hospital. He could be in his own home or his own work site. The array of codes that are covered, that is the services that are assigned codes that are covered under this form of care, has greatly increased. About 80 new ones have been added just recently. The array of eligible providers, which was limited originally to about eight different types, physicians that you might expect, advanced practice nurse practitioners, et cetera, now includes people such as physical therapists, occupational therapists, and so forth. Again, greater access to care and lower risk for those participating. The government has also decided to waive the requirement, long-standing, that to be eligible for Medicare reimbursement, the physician had to be licensed in the patient's state. Now, this is a different proposition from the licensure requirement I began with. Licensure issued by a state is necessary for legal practice within that state. But in addition, the Medicare program required that in order to be eligible for reimbursement, a provider participating in the program had to be licensed in that state as well. Now that is gone. Now, it will probably be restored once this public health emergency is over, but for the time being, that rule is gone. There have been other changes as well. It was against the law to waive or reduce cost sharing, co-pays and the like, because it would violate, or so it was thought, the fraud and abuse statutes. That's been done away with for the time being. Providers can now waive deductibles, co-pays, et cetera, without running afoul of the law. There's available payment for remote patient monitoring for new patients, not just established ones, as had been the case for many years. And we can now allow payment from high deductible health plans before the patient has met the deductible. All of these things have contributed to make money more easily available for the payment for this sort of service. We've also changed the rules regarding prescribing, or to be a little more accurate, an exception to the previously required in-person examination applies now that we have a public health emergency, and it's possible for a prescriber to write for controlled substances, such as opioids, for example, and the like, even for a patient he has not previously seen in person, a big change from prior practice. We've loosened up a little bit some of the privacy rules, for example. We've made it possible for people to use popular video chat applications, such as Skype and Zoom, like this conference, for example, which previously were not permitted. We've also had some changes made at the federal and the state level with respect to liability protection for providers of care, always a big consideration in this country. All of these things, by my lights anyway, have made a significant contribution to the greater expansion of access to this form of care, and I'd like to think better quality care at lower cost. That's it for me for my formal remarks. At the end of my slides, not that you can see them, I have a couple of references that I don't plan to mention, except to say that they're there for anyone who might be interested. Thank you.
Great. Well, thanks so much. Let's see, Dr. Nanda.
Hi, good morning, good afternoon, everybody. Thanks again, Brian, for including me on this esteemed panel. It's great to be part of this panel. You know, the good thing about going number 3 is that I think both Wilson and Joe have addressed a lot of the regulatory stuff and so on in telehealth. So I'll just give a brief background about myself. And I look forward to a very healthy discussion about the unlock, as we have so deemed the topic to be. So I am the founder and CEO for Align Telehealth. We are the leading telehealth platform in telepsychiatry nationally. I am a trained geriatric psychiatrist myself. Founded this company over 7 years ago and grew this to a national platform with over 300 psychiatrists operating in all 50 states. And now we are part of American Well family. So interesting times we're in, you know, with COVID, it has brought about a significant focus on telehealth, virtual care, and really catapulted telehealth to the front lines of delivering healthcare to everyone, including consumers, providers, and so on. So I look forward to a very healthy discussion here. Again, our core, as you can see with COVID, we keep talking about a second wave coming. I think my biggest concern on the second wave is not the medical issues itself, but it is the toll it has taken mentally and emotionally a lot of folks. And hopefully we can talk to that through this. And I think a lot of this has been addressed through preventative screening, treatments, and so on in telehealth. We have seen about 40% increase overall in utilization of telehealth just for mental health purposes. If you were to look at data set like Joe shared, there's almost a 2,000% increase in web searches and utilization of telehealth. I think we used more telehealth the last 2 months than we did in the last 2 or 3 years collectively. So it has now been accepted as a form of medium to provide care, both by providers and consumers who are now worried about coming to the offices. I think there's been a drop in outpatient services, almost 70%. And so with telehealth, this has significantly increased over time. And so the hope is that we can sustain not only the good care we provide to consumers through telehealth, but also maintain sanctity of revenues, both from outpatient, the provider, the hospitals. And so hope to talk to all of you about that as well. COVID has caused significant fear and anxiety, and I think economy taken a huge hit. So all these things have been a perfect storm in terms of affecting us on our mental health well-being. And so folks are really going to telehealth platforms to get all the help they can. Almost 33% of Americans today are dealing with clinical anxiety, depression, and this has been a huge spike, almost about 25% more than what we would see otherwise. So telehealth is here to stay. We will talk a bit more on the panel today. So just to keep everybody in time, I will hand it over to Mike. Thanks again for having us on the panel.
Great, thanks. Well, I think Mike's still working on joining us. If he joins here, we'll jump back to him. But why not jump in? I guess I thought and again before I do jump in there, the Zoom platform does have this Q&A function. So hey, folks out there, if you have questions, please submit them. Please submit them through that function. But I've got a couple to get us going. The first one I thought for you, Wilson, Dr. Wang, was maybe just kind of like starting at the practical level. How is technology and how effectively is technology being used to address the current crisis? Where, from your experience, I'm curious also, tools that were maybe already available just being used in new ways potentially, or new deployments of technology specifically for the ongoing pandemic. Any thoughts on that?
Yeah, it'd be great to say that after 2.5, 3 months of really sort of intense care, lots of money, that practice has changed. But I think it would be fair to say that the advent of health technology has not come, and that would probably be pretty expected in a health profession that probably lags, even the restaurant industry by 10, 15 years in terms of innovation. But I will say that there is a lot of opportunity, and Dr. Nanda is an expert in behavioral health, and I would be interested in his comments. I think the opportunity is in looking at what doctors go through every day, right? That's the only way to change behavior towards like the health technology that you're implying would be a benefit. And I think the most obvious pass-through for every single healthcare provider is the electronic medical record. Essentially, most large health systems are working with electronic medical records that cost usually on average of $1 billion for a big system. But in survey after survey of the electronic record vis-a-vis providers, no provider thinks that it's helpful. And so I was just talking to my residents the other day, trying to, who cares what I say? I'm 50. I was asking them, the future generation of doctors, what could they have used? What did they learn? And they said to me, what they learned was we needed to have protocols, but not in the form of this huge database or research paper. We need to have these protocols linked up into the systems that we work with every day. Now, they're not engineers and they're not, entrepreneurs. So they're talking about practical access to things at their disposal. And what's at disposal is their electronic medical records. So I'd be interested to see what happens to the future of EMRs in this country, electronic medical records, because they're costing a lot of money, but I've never seen one research paper to show that they've increased efficiency or they've increased effectiveness of care. And we see what happens when electronic health information systems are divorced from what's happening on the street or what our public health bodies are trying to do, because they don't have any idea of what's happening in the hospital. Because, as Joe will probably attest to, there's a medical legal concept that all data is the facilities, and it is not to be shared, even if the intent is for the public's health. So I think the opportunity in health tech is to use what we have. That means that we have to repurpose the electronic medical records we have to actually support doctors in the care of patients and to disseminate information to public health bodies.
Great. Well, thanks. And by the way, I meant to add, anybody else want to add on to what he was just saying there? Please do jump in.
This is Joe. I'll offer this thought. The reason, or at least a reason, why EMRs have in the main been disappointing to clinicians, or so I think, is that they are less electronic medical records than they are electronic billing records. They were really created to facilitate billing and collecting fees. Not that that's unimportant. You can't run the hospital without it, obviously. On the other hand, they are not clinician focused. And I think part of the problem is that, and then as Wilson points out, there is this proprietary concept that the data may be the patient's, but the record encompassing those data belong to whatever provider created it. And perhaps I'd like to give the benefit of the doubt to the profession and to healthcare generally, privacy concerns are very important, and one has to be very vigilant not to allow excessive, too easy access to very sensitive information. At the same time, there's also the competitive instinct that has some play here as well, I suspect.
And I'll add to this, Joe, that especially when it comes to mental health, there are very few EHR, EMR systems that can be embraced. And that's a real challenge as we deal with. I mean, when I combine our platform with American Well, running the largest enterprise hospital system, and it was so difficult for us as individual providers to interface with hospital EHRs and EMRs. We had to work on creating modules just for that and algorithms for that as well. We do a lot of work in the emergency room, for example. And so one had to integrate the ER workflow with providing mental health services to that chronic mentally ill, patients sitting in the ER. So that was a real challenge. And I would add that the EMR, just like you said, billing and coding is important. And that is how providers survive. I mean, that's what their bread and butter is today. So that really, conforms and has to be a bit more provider centric. Right now, it's more centric towards the hospital and health systems as we see it.
Excellent. Well, thanks. And I'm happy to tell you that we actually have a question from the audience here that I think maybe kind of feeds into the next question I was going to ask you, Dr. Nanda, which is, I alluded to earlier too, I alluded to this earlier as well, which is, it's natural to think about health technology being used to address the coronavirus itself, diagnosis and treatment of the coronavirus. But as you were kind of getting into a little bit there, how do you see the ongoing crisis impacting the population past that direct use case? And I know mental health is a key use case, and and then really after, again, for anyone at all who wants to chime in is maybe making this more more real, more tangible to the folks who are attending here, listening. How is the tech being used to address those issues? Even examples or anything, but you know, one of the questions from the audience kind of feeds in there, I think, which is their question is, what are some of the technologies that will grow along with the increase in the popularity of using these new digital modalities? Sorry, that's quite a wind up there, but that's the pitch.
That's perfectly fine. That's perfectly fine. I'll wear my shrink hat to kind of dissect some of that. So I think the key thing here is mental health and delivery of mental health on a telemedicine platform is in fact pretty basic and very simple. I think it is one of the few specialties that is probably most deliverable, and it is time tested, has the best outcomes. You know, case in point, you have anxiety, depression. If it is teased out in good time and it is screened in good time, a lot of good intervention that can be made, which are profoundly effective. And that doesn't just help with your mental well-being, but it also makes you a better person productively, both medically, as well as from work standpoint, and so on. So when I went into providing telepsychiatry services, I had a very robust practice at the time, and I took a shot at this. I said, okay, I got to start seeing some folks on being a geropsychiatrist. We were subspecialty in geriatrics, the far and few of us, taking care of the elderly with mental illness, dementia, memory disorder, and so on. There had to be a way that I could access some of these consumers who were sitting home, sitting across state lines. And the only way I could do this was, initially I did this on a private platform by seeing them, and there were no payers who were ready to pay us for that matter. That has since evolved over time now to become a perfect, well, I should say perfect, a real science that is still evolving. And you know, what we've been successfully able to do through telehealth is provide a very comprehensive psychiatric evaluation 24/7 in the emergency room. We as specialists by nature go into psychiatry to have a bit of a comfort of life, i.e. not having to go to hospitals, not to ER calls. But with this platform, we've reduced our wait times. I think a national average wait time is between 8 to 12 hours this year. Chronic mentally ill patients sitting in the ER. We have been able to reduce that on our platform to about 30 to 40 minutes turnaround time, 24/7. You can just imagine a patient who's suicidal sitting there in pain who needs to be seen, and the ER panel is waiting for a consultation to come in. So it shows the impact, not just taking care of that consumer, but also improving throughput, so that we can get that patient out of the emergency room, move them out to the appropriate level of care, and open that bed up for a CHF patient coming, a stroke patient coming in. And now, today, what is happening nationally is more and more of our emergency room beds are getting clogged by the chronic mentally ill, the indigent who are there. And so I feel that telehealth is the only way we can come in and impact that and be able to improve throughput and just provide better consumer care. COVID has brought this to the forefront, not just the ER services, but into our homes now. Because, you know, with the current economical structure, what we're going through, the pressures on us, and I think more importantly, the disease itself, the scare. I mean, where are the patients with CHF, the heart disease? Nobody's coming to ERs. They are so fearful of the COVID itself. So where are they sitting? They're sitting at home. And to be able to provide a platform, not just preventative, but also curative in some way. And again, the only way we can do this is to telehealth, virtual care. And I think as we get into some of the AI questions, we'll address that. You know, again, it's exponentially increased. Like I said, almost 2,000% surge in telehealth consultations. I mean, I can just talk to American Wild. We have increased the platform, you know, from X doctors to brought in another 30,000 doctors, providers in the last, 1 to 2 months, just to keep up with the pace of the consults that are coming our way on telehealth through virtual urgent care, addressing the mental health needs, and as such. So I think they need to underscore, we should be concerned about the mental health wave that's coming, apart from just the physical aspect of COVID. And I'll pause there.
I'll offer a thought and follow-up. The question about what technologies are likely to grow, And I think just alluded to that briefly, will be artificial intelligence. I imagine we'll talk about that later. But I think that in connection with the growth of telehealth, there's also been a new emphasis upon technologies that will support distance care apart from telehealth proper. I'm referring in particular in the COVID situation to at-home testing for diagnostic purposes. Now, there's a lot of room for improvement in the technology as it stands right now, but there have been some recent and, by my lights, fairly ingenious steps taken in the direction of enabling people in their homes to obtain samples that can then be sent to laboratories where the diagnosis can be made. Samples using such things as saliva, which is easy to procure, wastewater, even semen, according to what I'm reading. And I can't say I've had any personal experience with any of these things. None of that technology existed back in the days when I was in ERs a long time ago. But the growth of these technologies is, of course, COVID specific, but I think it also ties in nicely with the broader concept that among the inherent limitations of distance care is you very often cannot do much in the way of laboratory testing, and you cannot do much in the way of diagnostic imaging. And we are developing ways to overcome that so that these things are now possible to an extent not previously the case at home or in situations far from where the analysis will actually be carried out, the interpretation of the diagnostic image or the interpretation of laboratory data.
I think it's really important to differentiate when you're talking about telehealth access and quality. So there's no doubt that access, because of COVID, has dramatically torn to telehealth as it should. In fact, my company has pivoted in that direction to provide telehealth to low and middle income countries. But about a week ago, we surpassed 100,000 deaths from COVID. But every year, more than 100,000 Americans die from medical errors. And that's in a face-to-face touching context. So imagine if you do telehealth and you've eliminated definitely one sense, and a lot of telehealth really is like the telephone health. So you've eliminated two senses. So you can imagine that there's a lot of risk with regards to not paying attention to the quality part of access. So I think the technology that develops alongside telehealth is the ability to structure the encounter so that the probability that the right care is dispensed increases dramatically. And as Joe was saying, and Dr. Nanda was referring to, that can happen with AI, right? But as my dad would say, don't give a lobster to a baby. It's not going to appreciate it. We might not have to do AI. We could just go for the protocols that all of us medical professionals learn, and that includes behavioral health. When you go to the diagnostic, DSM criteria, what medicines are given for what, it's not really standardized right now. And there should be a lot of respect and deference afforded to the physician, but it's also not enough, right? This is a public good that needs a little bit better performance, in my view.
Great, thanks. And I know, hi, Michael. Great, glad you're here. We had just jumped into a few questions, but I did, initially we had given each panelist a couple of minutes to talk about themselves and some initial perspectives and stuff. Do you think you want to do that now, and then we can, jump back into the discussion?
Absolutely. My apologies for being a bit tardy. I had some technical challenges, which are, the Zoom is pretty easy, but I seem to find the glitches. Anyways, yeah, thank you so much. My background, just briefly, I spent the last 3 years as a venture capitalist for a large health system in Northern Virginia. We had a $150 million fund that invested in various stages of healthcare technology companies, as well as investing in other venture funds. And so out of the 150 million, we had about 105 million invested and reserved. And prior to that, I spent the last 20 some odd years as a CEO of multiple healthcare startups, some publicly traded, some international, several different turnarounds. So throughout my career, I raised over 125 million and different types of financing, had 3 exits. So strong operating background. And, it's interesting, as So I take a more venture capital approach to the panel discussions and kind of the perspective, and some of the things that we're seeing from a VC perspective really is kind of playing off on what everyone is talking about right now, or just talked about in terms of panelists. We're seeing some really interesting technologies that are supplemental really to telehealth or telemedicine, however you want to place it. We saw folks like Teladoc and American Well doing really well, and a lot of other startups doing really well, but progressing in a kind of a nice methodical pace. And then of course COVID hit, and then everything exploded. So from a venture capital perspective, we're seeing some fantastic opportunities to again better enable the virtual visit with different diagnostic and monitoring technologies, whether it's software, digital health, hardware, whatever it might be, but to enable a more accurate, more really just more better, more close, I think, process or intimate experience. That's what I was thinking about, with the clinician. And so we're seeing lots of opportunities. The challenge that we're seeing is that some fantastic technologies, but the use case and the business case really needs to be thought out thoroughly. I think reimbursement by CMS has enabled a lot of business models, but we are talking to a lot of different folks who are solutions in search of a problem. And so I would urge the entrepreneurs to really think through how they take these new technologies and really try to model them up or partner up with folks like American Well and other telehealth providers, but really think through how that business model is going to work. So.
Thanks. Excellent. It does appreciate that, what you're saying. And it does, we had another question come in that maybe kind of plays off of what I think some different thoughts that a few of you have just been sharing on. So thanks to Michael Berger out there for asking this question. I can read it real quick. It seems kind of like a supplement on some of the things we're talking about, and you might have some to add too, Michael, maybe. But his question is, what are your thoughts on the future of implantable sensors? There are startups that are working on technologies that enable wireless in-body communication, implant sensor powering, real-time data exchange, and in vivo storage and nanodiagnostic therapeutic functionality of smart medical implants. Does anyone, we were just kind of talking more generally about examples of new technologies that are being enabled. Does anyone have any thoughts on that one?
So I could go first if you like. I mean, from an investor perspective, I tell you we like implantables because it does take a bit of behavior modification challenge out of it. So adherence tends to be better, which is good. Usage tends to be more consistent, which is good. I would just caution folks who are looking at those particular technologies, again, really figure out what it is you're trying to do and make sure that there's clinical utility that's attached to whatever you're doing, and that the use case is thoroughly thought out, the business model is thoroughly thought out. I'd say in general, we're pretty bullish on those types of opportunities, just because, again, in the past, we've seen some really good solutions to big problems really falter at the commercialization level because people are people, and they don't take their meds the way they're supposed to. They don't follow directions from their doctors the way they're supposed to. So, it's important if a technology can shortchange the behavior modification part. I think that's you're leapfrogging a really big challenge. You have other risks, like you have technology risks, FDA risks, and potentially reimbursement risks. But I'd say a lot of people overlook commercialization risk a lot of times, and that overcomes that particular one in many cases. So we like them.
May I offer a thought to that?
Please.
I think Michael's exactly right. This is very exciting. It's the remote patient monitoring on steroids. It's going to generate enormous amounts of data from which tremendously rich and well-supported conclusions are potentially possible. But at the same time, I'm the lawyer in the crowd, so I have to rain on your parade. In addition to the regulatory risk and the reimbursement risk, there's also obviously significant privacy implications with something that is continuously gathering information about a human being. And perhaps a little less obvious are two that are very concerning to me in my capacity as a defense type. One is hacking. It would be, unfortunately, altogether too, not for me, I wouldn't have any clue how you do that, but the bad guys know how to hack their way into the Pentagon. So if you really think they're going to be able to, not able to hack their way into Dick Cheney's pacemaker, I wouldn't bet on that. The other thing that's concerning is that the very richness of the data is also a liability concern. Reams and reams and reams of blood pressure printouts or whatever, in which one or two data points out of thousands or even millions is exactly the sort of thing that our friends on the plaintiff's side of the bar search for assiduously, and they're very good at finding them. And the cross-examination is not hard to imagine. So these are tremendously exciting, potentially valuable developments, but there are some legal risks that need to be considered.
I think, Joe, I think those are excellent points. And those are all considerations in terms of the risk analysis that a lot of investors look for. The good news is I think there are some decent solutions that are out there that at least try to address those. You can never be foolproof because you're right. If they can hack into the Pentagon, there's literally nothing else that's going to be safe. But you know, we do try to balance kind of the opportunity to improve patient outcomes, lower healthcare costs. Try to figure out how the balance with the risks associated with, honestly, cybersecurity is kind of the cost of doing business now. We've got a lot of bad actors that are out there, a lot of foreign as well as domestic. And so you have to figure that that's just a part of the consideration of company building and product building. You know, it's interesting. We do see some very vigorous discussions on liability as it relates to, do you do it or not do it? In other words, some folks, I was with a very large trucking company at one point that had a discussion on, do they actually figure out whether or not they should diagnose sleep apnea, because they have a very well-defined line item of 33,000 truckers, 18,000 accidents a year, $220 million worth of life and limb and liability, but that's a relatively fixed number. The question was, well, if they start trying to intervene, does their liability go to infinity because they couldn't figure out what liability might look like if they were trying to diagnose and treat but miss some. And it's kind of like, well, the cost of doing nothing was known, but the cost of doing something, which was obviously better, the perceived risk was higher. So challenging for sure.
This is sort of funny, and I never thought I'd be able to say this, but you know, Mike is awesome, and he's a VC, he's powerful, and he's bullish on implantables. And I have to say that public health people are not bullish on implantables. And I think it's not because they're not innovative. I think it's like, what is the intent of health technology? And let's go back to COVID-19. I'm Taiwanese American. Taiwan is 80 miles off of the coast of China. They get 2,000 visitors directly from China every single day. They have 23 million people, and they have 7 deaths. They have 7 deaths. They have 7 deaths because they just did the basics. They did testing of very high-risk people, and then they quarantined those people with support, and then they did disease surveillance. So I'm all for the technology. I think that's great. But it's sort of like my daughter is doing show and tell this Friday. She's really excited. She's never done show and tell. I said, what do you want to bring for show and tell? She says, a car. I said, well, how about the bicycle? She said, no, a car. And so I feel sometimes like that AI is the car when the bicycle would be a really good start. But of course, keep in mind that what is the role for AI and for different situations, right? Maybe, you know, implantables is good for someone with type 2 diabetes or something like that. That, you know, doesn't mean it's all or nothing thing. So, but I just want to say that public health people usually aren't, you know, bullish on implantables, just because I'll never be able to say that again.
Great. Well, here's one that I had, which I think the suspense may have been building on this one because I know it's come up a couple of times, right? And well, I like to joke that I get a nickel every time I talk about it, but I don't, but I wish I did. AI. I would love to hear, you know, I realize that term can mean a lot of things to a lot of people, but there is undoubtedly a lot of talk and probably, admittedly, a lot of hype about the role of artificial intelligence in addressing a public health emergency and in transforming healthcare generally. So how do you all see AI, to what degree is it being used now? And where do you see it maybe going? Any comments at all anyone wants to make that maybe build on kind of some of the interesting insights we've been talking about already?
May I just say one thing? So just interrupting here, we have 5 minutes. So maybe if everybody could do a little bit of closing remarks about this question. Do you agree with that, Brian?
Sure. Maybe one thing we could, one thing I did not want to forget to ask Joe specifically about is this discussion that has come up about permanence of the allowances that have been made and maybe what we can expect or where we should plug in on that. So maybe we can squeeze all that in. Those were kind of the two things on my list to touch on before we broke here. Hopefully that's okay.
Well, I'll try, but in view of the time, I'll keep this as brief as I can. First, of course, it's a guess. Nobody really knows. My suspicion is that a lot will turn upon how well the telehealth community performs during this crisis. If indeed we provide access to care, and we do it at lower risk and lower cost, and greater access, that's going to point the nation and the laws governing it in one direction. If, on the other hand, we're perceived as offering more than we can deliver, or more than we did deliver, or worse yet, we're seen as frauds, and there's already been some allegations along those lines, that's going to point the country in a different direction. I suspect that some of the reimbursement changes may turn out to be permanent. I certainly think that telework, broadly, not just the concept in healthcare, but generally, may very well be here to stay in a much larger sense than was ever the case before this happened. I'm afraid, though, that the changes we've seen that were favorable in licensure, in prescribing flexibility, in privacy flexibility, tort liability exposure, and the relative leniency of the FDA, I'm not at all sure those will linger, particularly because, after all, the laws that put those in place in the first place are still the law. All we decided to do was not to enforce them, pro tem. So I'm concerned about all of those possibilities, but I think a lot will depend upon how well we perform.
Got it.
No, I'll take it next. I think, and the leniency that you touched upon, Joe, is critical right now. I just feel that it has now taken telehealth and delivered telehealth in a whole different direction. And I believe it is here to stay. And I agree with you, we'll have to conform to the new rules of engagement, so to say. And this cross-state licensing has been a real blessing for us in mental health. There's such a crisis in the ERs right now. We've been able to deploy now our docs in different states immediately, overnight, where we needed to. I'll give you an example. I mean, a part of our initiative has been hospitalists, where we had docs going in, large system with Cleveland Clinic and so on. And we were getting calls saying, hey, I'm not going in to see those patients sitting in there. So what did we do? Overnight, deploy telehealth. Came with the coding, and we brought in the out-of-state, licensed docs who provided us the care. Tremendous. I mean, it was well received by the hospital, the community, and the patients and the consumers. So a lot of those things are going to happen. So I just hope a lot of us are here to stay. And one critical element is payers and being able to get reimbursed, because it is one thing to have all the science out there, but if the provider is not going to get reimbursed, who've taken a huge hit on the practices, this is all moot point. So we are now finally seeing that happen. That to Wilson's point earlier, if you're sitting in New York, you're sitting anywhere else, you can now get paid for those services in the urban and as well as rural areas, both for the originating and beneficiary side. So that'll be my 2 cents as we end the session. Thanks again.
Brian, let me take the AI, and I'll let Michael have the last word. I think I put AI sort of in the category of like blockchain. It's probably going to happen, but it's a little early. I think it's early because the patient-provider interaction is not structured, right? So basically, providers can do whatever they want, they write whatever they want, and then you have very sophisticated systems trying to pull out, the meaning. Well, the meaning is doctors follow protocols, right? That's why it's a science. And so I feel like the first step before AI is to get doctors to follow protocols and then share the results of following those protocols, and then look at AI, how that relates to, let's say, age groups, demographics, diversity, blah, 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 blah. So I think there's a lot of, it's the cart's a little bit before the horse, but the idea is to look at data for good, big data, then, AI, cool. But I think it really starts with structuring the provider-patient interaction for sharing so that you could do the AI.
AI will take the administrative burden down tremendously, and hopefully error rates as well. So if used, appropriately. So thanks.
Yeah. So from our perspective, just real quickly, we used to always have this running joke that if you didn't have AI and blockchain, that VCs probably weren't interested. And so we'd see startups that would always say, yeah, we have AI, yeah, we're doing blockchain, we're doing both. And so trying to follow what they think is a hot buzzword trend. And so that was
Right.
funny.
Wasn't there a tea company that added blockchain to their name in the market? And they had
Yeah, it was just, it's kind of crazy. But, you know, and there are some very real challenges to AI. And I think, you know, it was stated earlier by Dr. Wang that, yeah, you know, sometimes you don't really need AI. Sometimes you can have some good decision trees that are built in, and that kind of gets you to the right answer. AI can be overtrained, neural networks. And so there are different challenges that go about it. And sometimes, you know, we try to look for the right solution. So we think AI is really good for hopefully being able to help with workflow as well as maybe diagnostic or monitoring precision. But you need data. And then you have a lot of legal issues about data, how you train it, how you prospectively validate it. Does it get overtrained? Are you using it in the right population? So, you know, look, we like it. We understand it's a tool. It's not the answer to everything. We find actually there are more risks on business model risks and commercialization risks than there are technology risks. There are some exceptionally bright people in this world. And we think that there are a lot of ways that AI can be useful. But I think some folks, some startups tend to overestimate, I think, the utility and the value that it brings. So, you know, again, from an investor perspective, it's just a part of a tool in a whole machinery of a startup company or a growth company.
Great. Well, I think that, and you know, hey, to the audience, thank you for the questions. And I know that there's a couple outstanding questions we couldn't get to, and I had questions we couldn't get to, which I think really speaks to why this is probably, in my view, one of the most fascinating areas about how the pandemic, I mean, naturally, but the most direct area, but also just most interesting area about how the pandemic is gonna, you know, what the new normal is. So I know we're as they just noted, we're hitting a time wall. We've run out of real estate, but I hope everybody enjoyed the discussion here, and thank you very much for joining this panel. I don't know if there's any closing remarks from the organizers or anything like that, but I appreciate it myself. Thanks, everyone.
Oh, really, really great. Thank you, guys.
Thank you, everybody.
Thank
Bye.
you.
Stay healthy.
Have a great day.